painful is not. It's quite painful. Why don't we just play some little mid-thing with that?
Well, no, but there's some theory in neurotherapy that the sensation is actually important. You fix up the brain with the part of the body, and you take that away, and you go to the
Jennifer Bell
we included some acupuncture points. This is from the large intestinal floor, which of course is unpleasant to do and then there is 2 points on the back of the neck, which are very you have to be roughly in the right area. Large intestinal floor is not very long, well, in your case, you can a little scar here, and if you were taking a minor with somewhere around the scar, it's going to be possible of the scar, because if the scar is broken immediately, you won't get any effect. And then on the scar, you feel for the ridge of the occiput, and you have 2 points. One is an inch away, which is the letter 10. There's a lot of argument where exactly it is. The other one is 2 inches away. Greater muscle be between, but again, there's a lot of argument where exactly it is. And I don't think it's the last 2.
That's like that. Greater muscle. Treatment on the occipital.
Yeah. And this is very on the mastoid, it's a really, in this case, you really contact the mastoid with quite a large proportion of hard except the maxillary sinus needs a lot, and the mastoid. No, the mastoid is all right on the tip, no, under the tip, on the outside. So I put my finger on the tip, and then see where the lower extension is. Put it as close to the lowest pole as I can. Still keeping the this is a point where sometimes people saying also the tonsil injection, sometimes people get a blood pressure drop in their training, so then you have to get it flat in the chair until they actually get them up. Let's go back and check your shoulder. Thanks for bearing with us. You all right? So then we go to lunch.
Yeah, but he has to have it all the time, so it's a valid test.
Is your nose clearing up? Is your nose clearing up?
No, I didn't have a problem with it before. Upper part of the house.
No problem.
Okay. Well,
Yeah.
that's what they're saying.
I can still feel it.
So how much reduction is I can tell, like, just my experience. My experience is when there's the external rotation at the end range, there's less resistance, which is a very significant sign for me, knowing that yes, there was another component that you caught with having done this particular procedure. And then I asked him, sort of if he would rate the pain before on a scale from 0 to 10, on the sort of external rotation. I should have done it before, but how much would it be?
It was probably about 7 or so at the end range. Now it's maybe 5 or 4. And it came
those are the important guiding points that you have that lead you to the right treatment. This is a
Absolutely fine.
there's a further difference in the freedom.
Get it on the camera.
Just fight against his family.
Yeah, it's spotting us from that.
So, so for me, it is established with him that, going back in the history, that the minor flu that he had when the shoulder started, that was the precipitating factor that caused his shoulder problem. With him, I would also then tend to give him the influenza nosol on covering the biochemical, immunological level of this particular illness. And I would send him home now with the instruction to come back, to monitor himself how this is going here. If it's decreasing again, to come back at the time. If it's not decreasing, with him, since he's not bothered by it more than it is, and he's lived with it very comfortably, rather than making money of him, I would send him home with a pack of 10 of the influenza nosols in the ampoules, with the instruction of taking one nosol every week with a little straw, sipping them out, or you can actually, with the heel for us, if you saw it off, you can actually sip it out of the vial, one a week, and I would expect complete and total resolution of the problem within 2 or 3 weeks. And I would muscle test you, on the influenza nosol, and send you home with it. Often it takes only 2 or 3 of the nosols, and you would stop taking it when the shoulder feels like completely home. And as a byproduct, I can promise him that his knee is going to be a lot better. Usually for a few days or up to a few weeks with the first tonsil injection. And he would have to then take also the streptococcus nosol to further decrease the size of the tonsils and eliminate the tonsils as an interference field permanently. You could just do it with repeated injections, but if you give him the nosols, he's independent of you. Give him the nosols and that's it.
Did you do it with the nose without the injection?
I don't know.
Or somebody who won't let you inject them?
Yeah. My feeling is that you probably would. However, with this, when you do the tonsils and establish that there is an improvement of this condition, you then know with a high accuracy by adding in the strep nosol that it will further improve the same condition that you've been working on. Whereas if you just start with the nosol right away, and I even found the muscle testing in EIB somewhat unreliable. You don't know what the nosol would do. I mean, you know it would be good for him if you muscle tested or tested electrically, but you don't know for sure whether it would affect the shoulder pain. But this way I could predict that it will resolve the shoulder problem, and that it will probably resolve much of the knee. But I'm just, if you at the time when you had the knee injury, if you had the tonsils injected, they probably would have healed with it to get the knee, but there was one surgery instead of 3.
You've got playing basketball.
Yeah, but I've seen some amazing things on athletes that have treated, people with anterior cruciate tears, in my opinion, I'm not alone with that. The least of the problems with these, you can live wonderfully with an anterior cruciate missing and play football professionally. I had a number of players in Albuquerque that play professional football. If you keep the posterior cruciate tight, and if you keep the knee pain-free, and all the other things, you can do that very easily, often over the concert. Thanks a lot. We need to go to lunch. And after lunch, I would like, I know we're getting close in time. When you need to leave? 3. So I would suggest, could we meet here at 2:30?
What time is it now?
It's less than an hour. 45.
Well, then we have a short lunch.
40.
Okay, then let's make it 2:30. Is that right?
At 2:30, we want to talk about the TMJ, and a medical link here who has some wonderful background in the trigger point therapy of the TMJ, and a scheduled approach to treating the TMJ is just the best. And what I've heard, and I would like all of you to, especially the dentists, to come here at 2:30 and be here for that. It's something you're never going to hear in that concise form again.
We're going to have time for scar and
Okay, let's have a lunch.
How invented really the neurotherapy and the trigger point therapy for me is really like a extension, like I said before, of the neurotherapy. Just like the trigger points have been overlooked by the Chinese, and the neurotherapy has been overlooked by the Chinese. It's the third system that is so crucial. And Aaron has a wonderful examination on the TMJ, and I'm asking him to maybe using me as a model to show and explain how he works up the TMJ and which sequence he does what in the workup and the injections for it. And I think we're all right.
First of all, I don't know, you guys can hear me?
You're recording it.
Thank you for tape. I would like to take this opportunity to thank Ed. I think he's done a fantastic job. I heard about the biological dentistry to a physician that believes in what you guys believe in, and he said to me, you have to go there, and when I looked at the brochure, I said, I'm going. Anyhow, the way I've been general dentist was a course junkie. I've been taking a lot of courses in orthodontics, orthopedics. I have to give you a background where I come from. And I see here a lot of bright people. I'm very impressed. There are a lot of dentists and osteopaths and so on and so forth. They have fantastic results. And what Idrik said this morning is very true about summation. Sometimes when I work with a patient, we get somewhere and somehow they hit this perfect other connection, which is a chiropractor or whatever it is, and suddenly we switch. One thing, I'd like to add some of the things that Idrik does that work well with me with the examination. I follow pretty close to, I spend a lot of time examining my patient. And one thing I do different than he does, which is very important I find, is the first statement, I start with the patient and I ask him, please tell me about your problem. When did it start and how has it affected you? And I repeat that statement throughout the examination. The other thing I do, which helps me a lot, is when the patient leave the office and they want to be patients to be treated, I ask them to write a narrative report about their problem with their own handwriting. I don't get to take 12, 15 pages. And I do not accept them as patients unless they've written down. I find more diagnosis out of their narrative report than anything else. The other thing I do, also on top of the narrative history, I ask them to describe their worst day. Now, out of that, I get even a lot more. And out of the worst day also, I ask them to add the funny things. I tell me something which your friend, you don't even want to tell your wife about that. If you press this, somehow for a while that pain goes away. You know, like unimportant things. I find those extremely helpful in my practice, and you guys could try those little tricks. Now, treating TMJ, I've been treating TMJ since I was in school. That means since '71. I'm sure some of you have been treating much longer than I have. I find when you're treating TMJ for 15, 16 years, only 15 to 20% of my patients are really TMJ and dental related occlusion per se, as dentists. That's in my statistics in my office. We have a computer and all that. We've been taking good records over the years. So when we start a TMJ patient, the most important thing as a dentist, because dentists are a little different than physicians, our status is a little smaller than physicians, I start over with very non-aggressive procedures. That means I educate my patients first. Number two, we use different splints. We start off in my practice with what we call the soft splint. I know you guys all have different technologies. It's very non-invasive, and I start educating my patients according to most of Trevel's exercises, where I find they have to stretch those muscles, and I try to communicate with my patients to arrive at an exercise modality that will help them too. stretching certain muscles. Of course, after the examination, so on and so forth, we start with a very mild, non-invasive splint procedure and a physical therapy, which I'm sure you all have different modalities. I use a lot of janitor valve technology because I've been learning from it for several years. Now, I do not start trigger point injections for a while. Big reason is I want to find the patient. It takes me a long, some patients take me weeks before I take the needle out, some the next appointment. And I'm sure you know what I'm talking about, especially the way you treat them. But I have this very important relationship. Now, when we get to the trigger point injections, which is what you want to know, the technology we use, or I use, basically it's layering of musculature. I treat, let's say, whiplash injury patients, the ones I like to see because I treat them very successfully in my practice. We start with the superficial muscles. I start with the trapezius.
You want to show me that doesn't go wrong.
We, after palpation, we palpate the musculature, and let's say we go through the trigger point TP1, we all call the area, I lift the muscle, and I start from the anterior segment, insert the needle, look for the trigger point. Okay? And I start with the trapezius, and we go down all the way along.
What's your reaction when you find the trigger?
Oh, it's incredible. Like, you go on and you have different reactions. It depends if it's a satellite trigger or the main trigger. Sometimes you see a complete spasm, and the reaction of the patient, they know, and it's usually like the electric current goes right to the referral pain. For the trapezius, it almost 99% of the time goes right to the referral pain in the temporal area or whatever associated area. I do the trapezius, okay, and then we apply moist heat and we stretch the muscle, okay? But before we do that, of course, we take care of the nutrition appointment ahead, like we make sure they have quite a bit of vitamin C, B complex, and all the minerals. We send them to a nutritionist or to the physician. We cover the nutritional aspect first. Now, we do the trapezius, left and right, that's all, first appointment. Because if you did hit the trigger point, that patient that night will feel like a shark hit them. They really feel like it's drained out. Now, when they come back in a week, you check the triggers, usually they're taken care of. And if they have problems, the next series, I go to relate the scapula, is the muscle involved. And I go, usually levator, you lift the muscle here, and in this region, and you can feel the levator and the patient right away. They tell you that the pain usually goes right to the occipital region, and then you deposit the anesthetic and you take care of the levator. And at the same time, I take care of the splenius. Oh, well, I don't remember the numbers, but each muscle has its TP. I really recommend purchasing that Janet's book. It's the Bible. I mean, it's explained very nicely. So I treat the trapezius, levator first, and then the patient has whiplash injury. The third muscle I treat is the SCM. Well, I treat both divisions, sternal and clavicular. I lift the muscle, and I do the TP injection.
Not before you put I know about the trigger point in there.
Yeah, well, you can see that the actual clinical trigger right there. So, if you want to be a hero with your whiplash injuries, and you be the most famous guy in your town, trapezius, levator, SCMs with a proper split.
Your physical exam, how did you know that?
I've been doing this for so long. Like I do all the lectures, I do fingers of it. That's diagnostic. Because I can find TPs like just do it, do it, do it. Dentists have very dexterous hands, because we work with our hands, and dentists have very good fingers to find triggers. Right?
What are you looking for?
It's incredible how I can find it. I can find, now, there is a muscle which the dentist should have the forte at, facial pains, the masseter muscle. Now, I have been doing it for a long time, and just now, the last few months, I know how to find the trigger points of masseter. That is difficult. And the best way to find, you have to use different technologies, and it's not in Janet's book. You start, you open them out, and you parallel your needle with the masseter, okay? And you just go in there, and like a fan, up and down, and you can find the triggers. The anterior part.
You probe with a needle,
With the needle. They don't, once you get in, they don't feel anything.
and then when they have the referred pain, then you
Just
know
like
you're
a
there.
fan. When you feel it, you deposit. Now,
Where is the needle entering the mucosa or?
okay, okay, what do? You ask the patient to clench. You can see the border. Okay, clench. Open. Open. Clench. Right? It's right there. See? The border right there. Okay. And right there, I enter the needle, and I just, you fan it.
In the muscle?
In the muscle, you just, and I tell you, it takes a lot of work to get those triggers. I mean, I thought I was getting them before, just like doing the scars.
Do you just needle them or you inject them?
Inject propane. Like I use a lot of propane. But as Dietrich was mentioning about knowing how to inject the scar, now I learned. Like knowing how to inject the masseter is an art. You have to do it over and over and over. And I find right at the angle of the mandible exteriorly, I inject the masseter, and these also refer a lot of pain to the zygomatic arch and the ear area, preauricular pain, right there. But I do the internal.
You do that also from the same needle position?
No,
Or you go
from the
separately
outside,
from the
external. I find I can't get the angle unless I go outside, but the internal, as your technique gets better, you get rid of a lot of facial pains. And a lot of people have facial pains.
You go behind the angle, like in the sternal-mandibular?
No, I just find the angle, and you can see where the muscle masseter is there, right there.
Okay.
And I go in there and I just look for the trigger points. If you look at the book, it's very well described, right there.
Stomach 6.
Yes.
I don't know much about those stomach, I'm learning them. So, now the thing that I want to mention, how important is dentistry point of view for the osteopaths and physicians here. Vertical dimension is very, very important, because you could do all your work well, and if you, as dentists, we know if we have a class 2 division 2 collapsed spike, those are the ones that you have to give them vertical. Other patients I found in the last 15 years damaged, completely destroyed occlusion. I do this split work and the trigger points and stretch and spray and physical therapy, nutrition. You get rid of your splint and they're happy, they go away. But class 2 div 2, if anybody knows how to do orthodontics here, just to do an experiment, to prove it to you, just put 4 brackets on the anterior teeth, don't put any splints, and the molar band, and do a utility arch. Once you torque those front teeth forward, lower, upper anteriors, that's the best splint almost. The lower jaw just comes forward, most of the pains go away in the division 2 cases without a splint. See, I could do that because I have a very large pain practice, like what they call 10K pain practice. So I have done these little technologies, but I always start with the splint, which is, I start with the myogenic splint. I'm a lot into muscle, so I always start with a 2 millimeter soft splint, and I go 2, 3, 4, and I have a whole slew of technologies I use that works with me. Because before that, I've used many other splints, and I also utilize orthodontic orthopedic appliances to expand maxilla, so on and so forth. But that's
All right, do
guys.
you usually find a need to inject the pterygoid? The lateral pterygoid?
Okay, so talking about lock joints, try to inject I inject the lateral pterygoid, it goes pop.
Could you show us how to do that?
Well, I go inside the mouth, okay, behind the last molar, I bend my needle, go up, and watch for hematomas. and the upper jaw, and look for the lateral pterygoid, or I go, like yesterday you saw it, at extraoral,
Right.
try to find the lateral pterygoid. I find the lateral pterygoid in locked cases is in spasm. That causes a lot of the problems. That's a very nasty muscle. Lateral pterygoid, people don't inject. I inject the lateral pterygoid. All my colleagues have taken Janet's courses, and they're in our group. I don't know too many that inject the lateral pterygoid. They're just a little leery about it. I go after the lateral pterygoid, and I find the lateral pterygoid is very important. Other muscle groups for dentists, the inferior, like the digastrics, and a good way to examine them, just grab your jaw, and just grab them and just move. And you can tell if it's in spasm. If you have a spasm, you can tell it's not moving. And these muscles also refer incredible amount of pain. The hyoid, the digastric area. Like you have to really, as Ed mentioned yesterday, which I really like, palpate that face and that muscle. The muscles of the face and intraoral cavity. Just keep on palpating the ridges and the musculature, and you increase your dexterity, and you really find a lot of points that you missed, and a lot of times you don't need splints. You go after them, either you stretch them or you do injections.
What is the profession
As I said to you, I start with the trapezius. A lot of times, you get rid of the trapezius problems, the levator, all the others just gone. Just like your technologies, you get rid of one, the major one, and the rest just boom, go away.
Just do one per-
I start with the trapezius.
But also like to make sure, and that's why everyone has to read the chapter number 4.
Chapter 4.
And book on the vitamin supplements. So very often, because of fibromyalgia syndrome, it's very, very often you go away by supplementing with the something, and then you just let instead of 50 10 areas, you let them go
So let me give you a couple of examples why chapter 4 is so important. The perpetuating factors are going to make you or break you. And the narrative history shows me a lot. For example, I couldn't fix this young lady headaches up there, and then one day I asked her, I said, write me a narrative history of last night, what you did. Finally she said, well, I watched TV. I said, well, how do you watch TV? Well, she watches TV laying on her stomach, looks that way. You open Janet Tervel's textbook, it tells you exactly that causes that pain. So narrative histories of patients are very important. What they did that day and 3 weeks before that, that really does help. The posture. Posture is very important. The medical perpetuating factors are very, very important. So we have to work together. We have to work with our medical colleagues, osteopaths, physical therapists. I just can't do it by myself. And I find this group really stimulating, and I didn't stop by taking notes here.
What about a patient who presents with a constant pain in the eye?
Well, try that SCM. Behind the eye, forehead pain, SCM is just incredible.
So you go to the whole three points and
Both divisions, clavicular and sternal divisions. And we have to really lift, that's an area which, we have to lift the muscle up, and I inject it like sideways.
Can you just show?
Okay. Line on the table and I'll show them how I do it. The way, one secret I have, I make the patient lift their head. As they lift their head, it just sticks right out, and you grab it, it hurts. See, now I have it all in my fingers here. See it? Now he's relaxed, it's right there.
just lost our lives.
Now watch this. If I start it now, as he is now, I really can't get it. Now lift your head up.
It's there.
There we are back.
Okay. Well, you try muscle, patient lying, you just don't get anywhere. You ask them to lift, you put you support their head and you grab the muscle. Now relax, now I have the whole entire muscle between my fingers, right there. Both divisions, alright? Okay, now, I usually start from below, but on the top, I go lateral this way. And of course, you aspirate in this area. And then on the lower, you just lift it right there. And you can find the divisions. It's just practice makes perfect. Lift your head again. See, it's distinct. You grab the external divisions right in my fingers. Relax. It's right in my fingers. Can't go anywhere. It's right there. And it's so neat. Right there. Just inject it.
Generally, when there's a problem, you touch that, you can get the referred pain.
Oh yeah, well, he's got one on the other side. It's pretty painful. Pardon? Good to catch. So,
Thank you.
Thank you.
I have a quick question. How much local anesthetic do you commonly use for like?
for my entire treatment, I use one dental cartridge, 1.8 cc. I don't use any more for
Per point?
open point. No. Just as you were doing with your circular thing. Exactly.
Very little.
Very
You
little.
only inject when you actually hit the trigger.
When you hit, I go all along the muscle. When I hit the trigger, I inject a bit. But also, being a student, I always veer off. I've been doing what you guys do. Like after I do the trapezius, I go in the area, go below here, and I go around and I deposit some and I rub it in. And I find I get better results that way. Just not just the triggers either. I go beyond, I deposit the trapezius and I just rub it. So I
Sub-Q
find-
or IM? When you say you do the deposit subcutaneously or?
No, in the muscle.
Muscular, okay.
And I'll show you one thing I learned from really excellent practitioners about physical therapy. Some, like, come back a bit. Now, one thing, if a patient is from out of town, I want to teach the husband to do the trapezius and the levator are the main muscles that cause a lot of pregnant face pain. I grab the patient's head, let him relax. Now, I'm going to stretch, let's say, the trapezius on this side. What we do, the patient bend their head this way first, then turn. Okay, put your hand down. Now what I do, the patient pushes with their shoulder up towards my hand, count to 7 seconds, relax, and stretch it for 7 seconds, and rest them for 20 seconds. We're beyond, of course. This is I find this very, very, very good physical therapy at home. You do that 5 times. Now for the levator scapula, it's a little different. And you can feel the difference now when you do it. Patient's head, you turn this way, okay? Okay, then you tilt, and that way. Stretch with your shoulder, and relax. See the different muscles work? You could really isolate, with this technology, the trapezius and the levator scapula. And I find this very, very helpful.
So one is just in straight flexion.
The one is basically you turn and then you just turn. That's the trapezius. With the trapezius, you turn the head towards the shoulder and you do that. With a levator, you turn, tilt, and then you go that way, the opposite side, and you isolate the levator. And I give this exercise
So
with,
there's some lateral flexion there.
that's right,
To this side.
Right side bending and left rotation.
that's right. That's very, very, that isolates. I give this exercise to patients from out of town, and their husbands or wives. They alternate 7 seconds, pushing against you, in 7 seconds you stretch, like called isometric relaxation technique. And that's what I utilize, and that's very helpful on top of the stretch and spray techniques I've learned from Janet Trudell. I find these very helpful. After just a couple of appointments in doing the basic musculature, a lot of the pain is gone. Now, when it's more chronic, of course, a lot more happens.
Do you find that tinnitus and some
discrepancies in deafness, hearing, do they clear up at all with this?
No. I think the other technologies the other gentleman gave us, they help more. Thank you.
Thank you, Ara. I got Ara's address in case anyone needs to know. I would suggest in the next course that you know, they put on to include Ara and for maybe the whole day or something from work. We've got some of the pieces of information that are very, very difficult to get in an accurate way. Thanks a lot, Ara.
Thank
treatment, they just need to be more often. You always go, tell the patient they can come back, or the pain comes back, or the problem comes back, and they'll give you an insulin. You don't stop until you're there. Sometimes it's not to take, I find especially in some older people, I find some people that you see a pain like that, or very rare, because you know, 3 times so there's no whole life. So people do more. If you give me permission and I test you on the feeling, as I said, like in my experience, often like when it's done only a couple of days or a few weeks with the new therapy, if you have to keep energy to it, you often get the last thing. Do you have the stomach problem right now? Now, with her, I would also, because of the time of the day from 3 to 6 o'clock, I would also suspect there was something in the mouth. And I would probably throw in the additional treatment of the lung also somewhere along the week, see what that does. That can be a very valuable thing to do, and I think all of you should be familiar with the Chinese organ watch, organ clock, and all the time, especially for people on headaches and important, usually they're driving. What's the opposite? I don't know what the lung, what you don't have any
It's just that when I have it, they come on each day different, and then from one side to the next. Sometimes
That would be sort of typical implementation point that we have to be on the ground, on the diagnosis, so you don't have to put
and decide I'm sure I have so many very random because I was thinking how to do it, but doesn't have neural terms.
it is even the difference of most of us doing more therapy than more traumatic. The problem with homeopathy is not that homeopathy is important, but it's finding the right mechanism and staying long enough with it. I've seen I use the fact that the past for homeopathy years ago, and it's just continue to keep somebody from taking one from the other before you get there. You need to trust, they need to bear with you. And I found especially in America very difficult to take it from because they had problems for 20 years, but they don't really do much before they get there. And you remember the drawing with the glasses, so slow that the glass got affected and not complicated. And you can't see it very hard, very, very stuff. And you have more complication than you know, or more. It is where the field populations come really from that. Really because you're guessing and a wider range of more likely to see. Well, it's once it tests you quickly.
Why do you think she's not holding?
But she's not holding. Oh, I think she had 3 treatments. How long was the longest relief you had?
The last time was 4 days. The last.
Can be, you know, it's gone, you know, can be difficult to treat because of two things. One, the moment it's gone, if it takes that to the injections and many done at the same time in order to stabilize and so on. In experimenting, they need putting some fluid in the most gone and it's really much different. You know, I think the moment eliminates the more quickly. And the other one is from the German studies, the very quickly in the scar, there's some powder surgeon's glove surgery embedded in the skull. There's this very bad penetrating factor that you often get 5, 7, 6 on the skull, and then another people scar 6. So there's improvement for 3 days every time you do it, and no longer improvement. There's a mechanism, and it's not the scar, there's one scar, there's one scar, that powder, perpetuated in the spirit. amount of testing.
A question about the scar removal surgically. If you decide to do that, do you just leave it open, or do you try to close it? This is important.
You know, I do. I've done a number of them in my office. I take a scalpel and cut it out with a nice clean edge, and the suture is not deep. You don't need to go deep. It's usually in a superficial layer, and you test it out with your injection. By doing the most superficial type of scar injection, that gives you 3 days of immunity. You know that your problem is in the most superficial layer of the scar. You don't have to go all the way down to the fatty tissue. You just go within the skin, excise it, and suture it primarily. Very loose suture, so that I find that the cosmetic sutures that have been done in children and studies of the arm and give you a scar in the skin and strong, invisible. Those are the worst scars ever until they tight. The loose tissue is tight, the loose floppy scars on the ground, even though that's a second law. But no, I suture it primarily and not using any subabsorbers or fluids for and suture very loosely and the patient can rather have a slightly bigger scar afterwards than risk it. So that's the one that you want to use blood for that.
I think those are the second worst scars. The worst scars are when they use this U.S. surgical staples.
Oh yeah, I agree. I agree.
So tell your patients not to have that kind of staple.
And it's silk preference.
No, I think plastic. Whatever plastic that because the plastic monofilament suture is the one that I pull it out and I just have it pull out. The silk is some suspicion that maybe because of the fine material that may need some placing. Yeah, no, she needs to. Yeah, no. What I just to repeat this, she's holding us together, is making this weak, and by me touching the sinuses is making it strong. Reversing the switching. That means when I'm, if you think of it that way, I'm energizing this area, it's making it strong again. So there is probably a residue of the sinus covering head in the past that's still playing a role in your whatever it is that's the problem. Very simple way, very effective if you do it this way. You find where you put most of the time in the head area that you find cause for the switching. Now, if I wouldn't go, if I wouldn't be confident in doing this, then I'll just show you the other way, maybe cross the left knee over the right like this. You can see she is neurologically very unclear of how to do things. It's very typical for people that are switched. She has
Did you, let's just ask another question. Did you notice sort of that your memory is very bad?
I have bad concentration.
Yeah.
And then on the evening, I don't remember.
Yeah. So she has very clear signs of neurological switching. That means some dysfunction in the work on the right and left hemisphere together. Now, her, I would put in my office on the color therapy. No, not do anything else to her right now. Just put her on the color therapy 20 sessions and know that I would lastingly change the switching, prime her nervous system, and eliminate a lot of the dysfunction that you find neurologically. And then go back and test her, and then treat what you find. However, like the testing of the science is always very
Did she at that where she had the weakness that came out when she was holding her right finger or something? Would you have done anything differently with that?
the weakness on the right side was only because she still had the left side from together. When she opened the left hand, it stopped the weakness on this side.
Right.
If both are weak, it's not an indication of switching, and there's something else wrong. There's a bilateral weakness and a different personality.
Okay, but say she lets go on the left, holds these things together, that's a little better. That's
Switching is only if you test the same way on each side, it creates weakness only on one side. So this other test was switching. I don't really understand the question.
Well, in other words, you have to do this, you test her, she's not weak. You say she's not together. Then you have to do this,
Then switching. If it is on one side, not on the other.
so it's
It has to be on one side only.
I want to mention also when I'm exercising and lifting my arms up, sometimes I seem to be heavier on that side. That side is looser.
Yeah. If people have like a scrambled brain like she does, so if you use it, the first muscle affected is the supraspinalis muscle. So that's a muscle you're going to be naturally feeling some heaviness and some affected. Let's test the scars in another way. Now with her, the testing is not going to be accurate until we treat the sinuses, but I'm just trying to see if we get any indication of the appendix scar, the other scar is resisting to she's hold it. Now touch your appendix scar. You have to touch it here. Hold it. Still strong. You know, touch it really strong. We have to take this with a grain of salt because she switched, and then the test results are very iffy. Can fool you, but on the testing now, it's gone ahead, shows to be a weakening in one of the appendix doesn't. However, I wouldn't trust this result unless we not switched her and tested her again. So with
But
her,
since she had relief the first couple, no, it's already been done.
Yeah, but this is
Been
more-
amputated.
and my feeling is the reason it hasn't been holding in her is that these two interference fields are again a chain in the series of interference fields, and her the sinuses are definitely involved. Let me just test your sinuses directly. Hold it, hold it. Hold it extra strong. Okay, now touch your sinuses here. Hold it.
Can you surrogate
We
something
could,
switch?
yeah, good idea. That's usually what I do in my office. If I have somebody switch and I just can't find the damn place where it's coming from, which is frequent, I get my nurse in and test on her. We could do that quickly. I want to move on to it because you have a lot of ground to cover. Let's just do the two scars. Keeping in mind that maybe tonight, if you still have it in you, I'll give you the sinuses.
Yes.
And I think you should have, where do you live in which area?
Sonic Cruz.
You could see somebody doing it. I think you need to light therapy. There's some people in your area doing
Jeff Lester does it.
Jeff Lester, oh yeah, he's a captain
I think we
in
can like
Watsonville.
that.
Okay, he's wonderful, yeah. The other thing I find works for switching is educational kinesiology, which is a wonderful technique. Anyone who wants to practitioner doing that is a wonderful artist, and they can also answer in your brain. The wonderful thing for you is going to be that your brain will be starting working again. Your memory is going to be easy. You're going to be pretty much more, storing, and it's probably going to take care of all this. So let me just kind of repeat this. In her case now, from the history, she got approximately the same pain relief every time when we had cushion scar injections.
After I had the injection, I felt almost better the next day. I had such high energy, which I
Yeah.
don't remember having.
So with her, there could be a perpetuating factor either within the scar, like this, or a factor outside the scar. Now, by doing the muscle testing, I'm finding that she switched she's weakening and touching the dysfunction of the hand position. This function is unique to the humans. Animals can do that. It requires both the left and the right hemisphere to work together. This person in the brain release that one part of the brain changes to listen. This is why this testing requires the coordination of both parts of the brain. It says weakening it. It means for this person to coordinate the left and the right brain in itself is a brain energy. Exert effort to coordinate both brain parts work together. This is putting us on the trail that there's something happening with the brain. And switching was corrected by touching the sinuses, which means that most likely the penetrating factor of this is an interference field within the sinuses. It's a little difficult to follow, it's a little bit like mathematics, but if you start playing with this, it's going to become very easy and natural to you. If you want to get, so I call this sort of higher round of therapy by getting into the fine clear scars.
What color do you use to correct which?
Well, like I said, there's a whole evaluation that goes with this instrument that very sophisticated. It takes a couple of hours to do it. And there's not one single color being one single condition. It's definitely obviously a single color being that person. It goes to the eyes, works to the pituitary and to the limbic system. That's the one thing that's discovered fairly recently in anatomy, that there's direct nerve fiber connection from the retina to the limbic system, which is mainly the effect of all of this.
You ever use flyboard therapy? Sound.
Yes, but I don't use his tapes because they're $120 a piece. I use music, like I said before. Like
$270 a piece.
Incredible. There's some people in Germany who send me their tapes that's been based on different types of research that seem more effective than the flyboard tapes, and they only $10 a piece. I'm trying those out right now. Just going up some
Sure.
I don't know.
Did you measure like triple warmer 20?
What do you mean?
Well, you use like that?
Yeah.
If you measure triple warmer 20, what would you expect on?
I don't know. I haven't been using it in that way. I don't know.
Maybe we can inject someone that had tubes in their ears as a child.
Okay. We get to that's what I'm trying to get through the whole day, like to run quickly through the main indications of what we do when there's an ear treatment that's wonderful, very simple, very effective, and then we're going to get to this next thing. I just want to start with the scars. Once you lie down. Why don't you all come here and just look at the scar treatment, because one thing you always do with a scar before you inject it, you check for mobility, how the scar is moving on the fascia underneath. And with her, you find there's quite a bit of resistance, and especially moving it up, so she doesn't scratch.
Virgin,
Yes.
would you get me that microphone standing here, like for, testing procedure stuff, please? Now, when you do testing, it's always important, this one we can be blind here because we already injected that and already assume we can't get here with that. But these substances that you test, when you do your glucose test at the beginning, you have to keep it away from her body and your body. So it's not good to stand here and test her because this is already testing the stuff in her circuitry. So we have to have it away, and also away from people, because people can work as radio
button is an important area, and amongst testing, people that are not switching will show you whether the belly button is involved or not. Belly button is very, very important if you have children that have no accident. That's in about 70% or so of cases with the belly button. There's often only one injection. Colleagues and babies, we always go back and people that have history of asthma from the time started in the say the first year of age, you always want to do that belly button. I have worked with one laser that I had for a couple of years that I sent back to Germany because I found just didn't give me anything on the end. I think if you have a fairly strong industrial type of laser, I think you may see some good results. I've been very disappointed with the interest in this one. Yeah, I know. I mean, it's a good point. I think it would be worthwhile, if you try using a laser on it first, and then to see where you can see it. But keep that in mind, any childhood disease, that when you trace it back in the history, really started within 3 months after the end of the belly button, that one of the first growth in the first 2 months after the initiation. So that is the whole group of eczema, colic, asthma, and
But
But in order for that, and you sort of move the skin in a way that you can follow the form of the skull more or less.
The needling is what scar out. Until when?
Well, this is just a dead scar, almost like what I'm squeeze it out. I would do my homework and I would be really
Yes. 719.
Well, it's okay. It's okay, no, but even now I feel that I just also take a mental note and next time with a bigger scar, get good pressure.
Large intestine, herbal generations all cleared up.
Kidney one.
You can think now, right?
yeah, okay.
Okay, everyone take a seat.
Test the tape cavitational osteoarthritis with an intraligamental injection, do
No, I don't. I
So what's the 30
Buckle
gauge
and
needle?
buckle.
And in her case, you would have really needed a 27 gauge. With the scar injections, I usually always use at least a 27 gauge or less, because you want to get the fluid pressure right in the scar to separate the scar from itself, separate the cells within the scar tissue. That's where the whole secret lies of this. And with a 27 gauge, it's nice to do the acupuncture point and the dental point with a 30 gauge. But for the scars, you need 27 gauge or less. In children, I always use a 27, in grown-ups usually 25.
Just notice, speaking of original scars, what about circumcision scars?
Yeah, I've done a lot of circumcision scars. Amazing how many men are afraid of doing that one. I believe the number of cases, two cases recently of severe asthma since childhood that were relieved by injecting the circumcision scar. And if you ever plan on having any children, I think it's a terrible custom that's really medieval in nature and has no medical justification whatsoever anymore. And I'm amazed that it's circumcised and disagrees.
Yeah, and I've always fight with doctors on that. And it's usually, the pediatricians came out with that when I was in medical school. Well, the problem is their medical experience is broad enough. And there's a certain percentage of little boys that cannot take care of it. And then on the other end of the scale, the stroke guy that I showed also got a balantitis. So if they get disabled, they can't take care of it on the other end. And there have been studies in the literature saying that the majority of circs are emergency circs. And so I say if you can somehow warranty that child that he's going to be able to maintain it, pull it back, and clean it from the time he's old enough to do it himself, and his parents will do it, and he can do it in full spectrum of his life, well, he doesn't need a circumcision. But if he's going to get a stroke or get disabled or not really give a damn about brushing his teeth and pulling back the foreskin and doing other hygienic things, they should be circumcised before they get out of the hospital.
Of course, there's some medical indications for it, but I think the custom here in America that little boys, no matter what religion or sect they belong to, get circumcised, I think is very terrible, and is in psychology stems from an unconscious hatred towards men that many mothers have. And I've seen many people, I used to be a surgeon, and I used to see many women coming with a glee in their eyes that their boys finally old enough to have them circumcised, couldn't wait to have them circumcised. And I think there's a lot of subconscious stuff that feeds into that, and I think that as a habit needs to be broken, and I think there's no medical justification in doing it prophylactically. It's like prophylactic hysterectomy or prophylactic testiclectomy, and I think it's not justified. And we know the study has been done in Israel in the 1950s, where cervical cancer was linked to men not having been circumcised. That means introducing some dirt or so. We know from the man who died, who did the study, that on his deathbed he admitted that he faked all the drugs that were came out of. And that's been used as justification in medicine. One study that was done in 1958 in Israel was used as justification for a whole country, for millions of little boys being circumcised and ending up with a deep subconscious trauma that something's wrong with their genitals is really the outcome of it. And I personally think it's one of the reasons why America is sexually so screwed up in the brain.
It also carries a significant morbidity and a certain degree of mortality, which I personally believe. One question, if you've got a scar that's very bound down, like I've got a couple of patients I can think of with scars that are very, very adherent.
Okay, now I have to admit, something I don't like to admit in front of a group like this, but these are the patients where I tend to add in a little paracetamol and a little steroid within the solution and use a huge amount of solution, up to 30-40 cc, to really get every little corner of that deep adhering veins that are deep in there. I use a small amount of steroids and then I follow it up with cortisone also for a couple of times to undo the steroid side effects. But that's the one place where I found it that the results improving problematically by using.
Have you ever used Highlight?
What?
Highlight?
Hyaluronic acid is what you're talking about. It's advised not to use that because of allergy. High amounts of allergy with that.
One thing that I haven't pointed out, but in the B-venom is hyaluronidase, and so very often by doing the superficial B-venom injections, and adding in B-venom, you also get a resolution of these. But if they don't, I use steroid. I've seen only 2 cases of where hyaluronidase is needed, and I've been using some thiocyanamol, that's a homeopathic scar dissolving remedy, which is very potent. As well as I'll put you That's close. The complete proof as that one. And that's the main homeopathic to the dog scar tissue. I've talked to a colleague over here. I used to use it epidurally until I had one event where it proved to me that the solution isn't quite sterile, unfortunately, even though it's in a handful. That's one of the proof preparations. So, the one thing to keep in mind, you can't always trust the German homeopathics that they're really absolutely sterile. I had one incident that really proved it to me. And since then I stopped using it altogether. I started going back to 2 cases of using steroids. Before that, I would have used that muscle tested the right potency of and get wonderful results with the resolving scar tissue. I want to go quickly from top to toe with you over the different procedures. First one is a crown of thorns. Did you see that demonstrated here in the last few days? Okay. Next procedure is the one with ear injections. Very injections, very important. They're used for tinnitus, for Meniere's disease, for hearing loss. I had a wonderful experience of that. I was in this German neurotherapy clinic in December, and they asked me to see a patient that they had that they treated with stellate ganglion loss and all kinds of other things. And she had loss of hearing after a cold on one ear. And I asked her what kind of procedures they'd done. They'd done everything, all the scars, injections, stellate ganglion, but nobody treated the ear itself. She'd been going to the clinic for 6 months or so. And I did 4 ear points, and she had hearing back. And back. At least for the week while I was there, especially when I thought I was God or so. But it's usually where you start first before you do the other thing. I don't know why they didn't do it there. And I like to, you have in your handout that did you give it to everyone the big file with
everything.
Okay.
Those 5 pieces of paper.
Okay. So you have it in the book, but I'm going to go over the points with you. There's 4 points that you inject, both superficially with a little wheel and go a little deep. There's about half a cc of local anesthetic of each point. The first one is you take the tip of the ear, go from there to the skull.
Do you want to do me? I've had tinnitus for 30 years.
Wonderful. Once you come up here, okay, well, everyone with a bad ear come up here. And we won't have time to go into history because many times it's a scar somewhere else. But the first line of defense is always to do the ear itself. But I want to describe the points for everyone quickly. So the first one's on top of the ear. You palpate the skull and move your finger up until you fall in a little groove. About half an inch up from the ear. I don't know. It's named
Gallbladder, right? Yeah.
Okay. Next one is on the tip of the mastoid, just like in the sinus injection. Palpate where the mastoid is. The right dot on top of it. The third one is what's called the gate of the ear, acupuncture point. It's in front of the tragus here. And it's like an anterior to the groove.
Small intestine 19.
Inferior, right here.
Let's look at that. You have the
Silvers.
I've done only about 500 of these, but I'm getting
Does anybody have a syllabus to look at it? It's in there.
I hope you all have that. Because Ed and I worked last year on that. I sent Ed all the German stuff, and it's a wonderful, wonderful compilation of things.
There's an index in the front.
Yeah, got a good index and it's one of the best books on acupuncture written. Oh yeah, okay. The gallbladder 2 point, and this is one of the acupuncturists here who was in what happened to the treatment. If you just vaguely right, you don't have to be an expert. Let's treat you.
And that would be even in relation to drug-induced tinnitus.
No matter.
Doesn't matter.
Yeah, that's on the word. Ed, would you draw us up the switch here? page 92. It's a wonderful book that Ed brought out last year, and really has a lot of it, has all the sinus injections in it, and all the major things that you will forget on your own.
How deep do you go in that last section?
I show you on him. Now, let's quickly muscle test you on a few other things. When did it start? In your 20s. Do you remember if there was any preceding trauma? Okay. So, here is there
30 gauge?
is that something that runs in the family? Anyway, it came on in him in the 20s. It's only on one ear. It's almost certain that it's not genetic, but was a sequelae of some sort of trauma or infection or something that happened at the time. Because in this case, then of course I would go a little bit more in the muscle test, and you can check for the tonsils. You would think head trauma, and you have an accident, like a concussion or so in your 20s, like a motorcycle accident, something like that. Colds, of course, would be the most likely reason. Again, the tonsils and the sinus are the most likely cause of it. Did you have an appendix operation or tonsil operation? Appendix, so it was many years before, but again, like something to keep in the back of the mind that the appendix scar or any scar that has occurred before could have been asymptomatic for a long time, and then in combination with another link of the chain have become the single factor causing this ear problem. Very important for ear problems also the teeth. Do you remember the history of the wisdom? So we're getting a little closer in age to the onset of this. 17 years the wisdom teeth come. Any other dental problems that you remember? Root canals. Root canals. After the appendix. Okay, any other scars? Any other problems that you remember, any surgeries, fractures? Fractures, I forgot to mention, very important scars, the bone scars. You can, if you disinfect a little bit more carefully with something that's brown, better than one of the other brown things, that very freely go onto the scars. Fresh fractures, just to mention that here, if you have fresh fractures, please treat them right away. When they come in your office, and before you send them on to your orthopedic surgeon or whatever, inject a good amount of local anesthetic together with small needle into the fracture. You're going to see the most dramatic, incredible things from it.
Betadine on the surface.
Yeah, those are always useful. Betadine. The old ladies that fall on their arm and fracture their humerus. People are the most wonderful patients, but with one injection, you almost completely relieve the total pain. They start mobilizing the shoulder after 2 days. But after a week, they have already full range of motion with the broken arm. And you go right into the fracture. You search for the for the fracture, and there's local anesthetic, maybe 5 or 6 is a handful of trauma. Wonderful treatment for that fracture. Trauma goes away, swelling goes away, fracture heal in no time. Anyway, so with him, we have a little bit in the back of our minds, appendix scar, the wisdom teeth that you had called before the onset of the tinnitus. We have a little bit in the back of the mind, may have had a bronchitis, for the chest is interference field, and for the sinuses is interference field. That pretty much covers it for him. And before we inject the ear, of course, we will do the quick test for what you lie down. Just run through quick muscle testing. I hope it's not switched. There's a book switch. Are you English?
It's a wind-up one, automatic.
Okay, that's fine. Probably if I was just beginning, it would have a one.
You used to have to be careful with
That's it. make a sound with my fingers and get sort of an approximate feeling of how much I need to do in order to make it clear. And it's going to be difficult for us to assess it very well. That should be very easy for you to tell afterwards whether
I like that. Yeah, but you'll do the same thing you do. That's the main attention.
do you mind sitting up for the ear? Why don't you come around and so first part, tip of the ear. Actually, it's one of the things that he has there. That's not my intention for me. I go both. I touch it near to the skull and pull slightly back. That's where my first droplet comes. And then on the way back, actually ejecting my way out. Next one is the tip of the next one. Put your finger underneath and on top. You get the lower location, like the lower tip of it. And this is where the ejection goes. Directly onto the bone. This one is fairly large and long, like this is a little bit more. Directly onto the muscle. Most important of these four injections. Then the base of the ear, I localize the anterior in the same in the same movement. Then I also like to go a little bit deep and then go there too. I always use to localize. Take the lower group here, make a straight line out. Across the state line of the here. There I like to get an acupuncture point superficially, go a little bit more deeply. So there's a lot of nerves and arteries where it has to break. This is probably the most important one from a neurological point of view. Because you actually catch some of the autonomic nerve fibers that surround the sheath of the artery that are responsible for directing the blood flow. Okay, this is all for the part for the ear, which is really very simple and sometimes can be very dramatic. Do you notice any change so far in the ear? So if you want to go straight, to the appendix, maybe the tonsils. If that doesn't do the ultimate best method you can do is to get a hands on block. I want to demonstrate to you how the technique would look like. Just lie down to give you a start and then
Did you do swallow test the 19th?
No.
It was triple heater 21 was the top one.
Okay, one thing I want to demonstrate to you, when you go back and check back with the muscle testing on the ear, hold it, touch it with the other hold it. It becomes strong like iron. That's when you know you've done whatever needed to be done in the ear. And it's very, nothing you have to be sensitive for. And the same, is true for the scar. What was the bevel facing up when you inject the scar? Very important for separating the most layer. So you want to really see the many tip right into the circle of the skin and know that you're
Right by my yellow.
I bet it. Well, I mean, the number of people that had all the tools, from the neurologist to all the bodies, and all the tools that we have here neurologically, they make no difference. So, okay, now the tonsils with the inner ears, I find most often being very effective. I don't know why. Tonsils I find the most effective. So never stop short of doing five
Just tell them what you're doing.
These very small shriveled up tonsils that you find often after people have tonsillectomy and go back in. But I think this is like a moment. This is one thing we need to think is really important.
Going in about a half inch.
Yeah, what is your half inch? No, I like with him, since he's just in position, I like to show you the stellate ganglion blocking below. In him, I would like to do it first thing. I want to see how the local aesthetics work long term with him. My stellate block, I never do the first time. I take too much. Yeah, too much. Hold it. you a rough outline where it's going to find it. Now, you take from that, sit on the maximum machine and have to wait. Without being third, because people would say, three people are about easily long. This is the other way of determining the level. That would give us about this level slightly down from this one. So we have two independent ways of determining the ultimate level. And then the insertion point is at the anterior part of the sternocleidomastoid, the intersection with this line. So we have an area rather known at one point with two ways of determining that from here to here all these points will be obtained. Now in him, this patient with a rather long, nice neck, but there's virtually no risk of even a short neck. That's the one way of worrying about. But people like him, we can be very confident and see that very simple and easy. I use a 3-inch spiral needle. You really need only 1.5 inch needle. But the nice thing with these needles, that the easy 25 gauge needles, that they have a fairly blunt tip. And with this one I've done dozens of very blunt last year.